7. Pelvis and acetabulum. Anterior approach. The pelvis is a complex bony structure with interconnecting ligaments. It consists of the two innominate bones, which articulate anteriorly with each. 654. Other at the pubic symphysis and posteriorly with the body of the sacrum at the sacroiliac joint. The bones are covered on each side by muscles, and the intra-abdominal contents make surgical exposure potentially complex. The presence of a large subcutaneous surface, the iliac crest, however, allows safe access to the ilium. 5 approaches to the pelvis are described in this chapter, all of which provide access to the bone via its subcutaneous portion. Anterior and posterior approaches to the iliac crest are used almost exclusively for bone grafting. The anterior approach to the pubic symphysis and the anterior and posterior approaches to the sacroiliac joints are performed rarely. Their use is associated almost exclusively with the open reduction and internal fixation of pelvic ring fractures. Acetabulum. Approaches to the acetabulum are the most complex and demanding approaches a surgeon can be asked to perform. They are nearly always used for the reconstruction of the acetabulum following fractures. Because each approach only gives access to a limited part of the acetabulum, it is critically important that the correct approach is used for each fracture pattern. Figure 7-1. This requires accurate assessment of the anatomy of the fracture using radiographic techniques, including computerized tomography. 1 to 3. The use of a bone model is invaluable, especially when a surgeon is inexperienced. The ilioinguinal approach to the acetabulum allows access to the anterior column and medial aspect of the acetabulum. It also allows visualization of the inner aspect of the pelvis from the sacroiliac joint to the symphysis pubis. It does not allow direct access to the posterior column or posterior lip. See Figure 7-21. 655. Figure 7-1. To appreciate the anatomy of the anterior and posterior columns of the acetabulum, hold a hemipelvis up against a light source. These two massive columns can then be appreciated in contrast to the thin central area of the wing of the ilium. The posterior approach to the acetabulum allows access to the posterior column, posterior lip, and dome segment of the acetabulum. It allows very limited access to the anterior column of the acetabulum and no access to the medial aspect of the acetabulum. See Figure 7-39. The applied surgical anatomy of the ilioinguinal approach is to be found immediately after the description of the surgical approach. The applied surgical anatomy of the posterior approach is found in Chapter 8. See page 451. Because each approach only provides limited access to the acetabulum, complex fractures may require the use of more than one approach. Most acetabular fractures occur as a result of extremely violent trauma. 656. The tissues therefore are contused and muscle planes are often difficult to develop. The fractures themselves are difficult to reduce, and control and specialized instruments are necessary to ensure anatomical reduction. Acetabular fractures are rare. Understanding of the result. For these reasons, acetabular surgery, anterior approach to the iliac crest, anterior iliac crest bone grafts are the most commonly used grafts in orthopedic surgery. The iliac crest is subcutaneous, and cortical, cancellous, or corticocancellous grafts can be taken from it with ease and safety for grafting in all parts of the body, including the spine. It also is possible to remove pieces of the iliac crest, including both cortices, for major bone reconstructions, especially in the head and neck. For posterior spinal fusion work on conditions such as scoliosis, the bone graft usually is taken from the posterior aspect of the iliac crest. Position of the patient. Place the patient supine on the operating table. Because the graft is usually taken in conjunction with other procedures, the iliac crest should be draped as a separate unit. There is much to be said for preparing this area routinely in all cases of open reduction and internal fixation of long bone fractures. Place a small sandbag under the gluteoclenial area of the side from which the graft will be taken to elevate the crest and rotate it internally, making it more accessible. Landmarks and incision. Landmarks. The subcutaneous anterior superior iliac spine, the most important. 657. Landmark is easily palpable. Continue palpating along the crest of the ilium until its widest portion is reached. At the iliac tubercle. The iliac tubercle marks the area of the ilium containing the largest amount of corticocancellous bone for graft material. Incision. The length of incision depends on the amount of bone graft that is required. For an extensive bone graft, make an 8 cm incision parallel to the iliac crest and centered over the iliac tubercle. Figure 7-2. Internervous plane. Muscles either take origin from or insert onto the iliac crest, but do not cross it. Therefore, the crest offers a truly internervous plane. The tensor fasciae lati, gluteus minimus, and gluteus medius are the muscles affected most directly by grafts taken from the anterior portion of the crest, because they originate from the outer portion of the ilium and are supplied by the superior gluteal nerve. The abdominal muscles take their origin directly from the iliac crest and are supplied segmentally. Superficial surgical dissection. Retract the skin and identify the iliac crest. Cut down onto the iliac crest with a scalpel. Figure 7-3. In children, the crest still may be an avascular apophysis. If so, incise it and remove the muscle through the crest in either direction with a Cobb elevator. No apophysis will be present in adults. Take care not to carry the incision from the apophysis or iliac crest onto the anterior superior iliac spine itself. If this occurs, the origin of the inguinal ligament may be detached and an inguinal hernia may result. Deep surgical dissection. The muscles may be stripped off either the inner or the outer wall of the ilium. Initially, cut down onto the bone using a scalpel. Follow the contour of the bone, sticking to it rigidly. Figure 7-4. Below the crest itself, the ilium narrows considerably, So the sharp dissection will need to follow the contour of the bone carefully to avoid straying out of plane and into trouble. After coming around the corner of the crest onto the ilium, continue the dissection using blunt instruments such as a cob elevator. The muscles will come away from the bone easily. Alternatively, push a 658 swab into the plane between the iliac wing and the overlying muscles. Using a blunt instrument, introduce more and more of the swab into the plane. The swab will act as a tissue expander, pushing the muscle away from the bone, while at the same time protecting the soft tissues. Coracocancellous strips may be taken from either side of the bone, or a complete block of the ilium can be removed. Pure cancellous bone can be taken by elevating a small piece of the cortex of the crest. Be aware that the largest supply of cancellous bone is directly underneath the subcutaneous surface of the crest. Figure 7-2 make an 8 cm incision parallel to the iliac crest and centered over the iliac tubercle. Both the crest of the ilium and the anterior superior iliac spine should be left intact to preserve the normal appearance of the pelvis. If the anterior 659 superior iliac spine is taken as graft material, the inguinal ligament might retract, causing an inguinal hernia. How to enlarge the approach. Local measures. Place a sharp-tipped retractor onto the bone to retract either the gluteal muscles from the outer cortex or the iliacus muscle from the inner cortex. Placing a swab between the retractor and the muscles creates a bloodless field and prevents little pieces of bone graft from being lost in the depth of the wound. Great care must be taken, however, to remove this swab before undertaking closure. The incision may have to be lengthened on the iliac crest, and additional amounts of gluteus medius or iliac is stripped off to provide a better view of the outer or inner cortex of the anterior portion of the ilium. Extensile measures. This approach is not classically extensile. The approach described in this section is merely a means of obtaining bone graft. 660. Figure 7-3 retract the skin. Identify the iliac crest, and incise the soft tissues overlying the iliac crest down to bone. Figure 7-4 remove the origins of the gluteus minimus and medius muscle superiorly from the outer cortex of the ilium. Posterior iliac crest bone grafts usually are taken during any posterior spine surgery that requires. The grafts also may be used as cortical position of the patient. Place the patient prone on the operating 601. Place landmarks. Palpate the subcutaneous posterior part of the incision. Make an scoliosis surgery or lumbar surgery is being performed. Using a internervous plane. Muscles insert into or take origin from the iliac crest, but do not. Therefore, the outer border of the iliac crest, the gluteus medius, minimus, and segmentally supplied paraspinal muscles take their origin. Thus, an incision into the iliac crest does not denervate muscles, even if it is not placed exactly. 662. Incise the soft tissues overlying the crest. Make an 8 superficial incise. In children, the iliac apophysis is white and quite visible. It may be in adult. 600. Crest both medially and laterally to bear the surface of the posterior portion of the crest. Dang nerves. The cluneal nerves cross the iliac crest. They can be avoided by placing the incision no more than 8 centimeters anterolateral to the posterior superior. The nerve supplies sensation to the skin over the cluneal gluteal area. They are composed of the posterior primary rami of L1, L2, and L3. Their loss does not cause problems for the patient. Deep surgical dissection. Strip the musculature completely off the posterior portion of the lateral surface of the ilium so that a large enough graft can be obtained. Take care to stay in a superiosteal plane while passing from the iliac crest to the outer cortex of the ilium. Proceeding 1.5 centimeters down the ilium in the area of the posterior superior spine, the elevated posterior gluteal line. Do not err by letting the line direct the incision outward from bone. The talar retractor will help the exposure by holding the muscles laterally. Note that the posterior nerves. It is remotely possible that an osteotomy will hit the sciatic nerve, which runs close to the distal end of the wound deep to the sciatic notch. However, if an imaginary line is drawn from the posterior superior iliac spine perpendicular to the operating table, and all work is performed cephalad to it, both the notch and the nerve will be avoided completely. If a larger graft is necessary, palpate the sciatic notch itself before taking the graft. See Figure 7-6b. 664. Figure 7-6a. Superiosteally strip the musculature off the posterior portion of the lateral surface of the ilium. Proceeding down the do not err by letting the line direct you outward from bone to muscle. If you draw an imaginary line from the posterior superior iliac spine perpendicular to the operating table and stay cephalad to it, you will avoid the sciatic notch and its contents. Vessels. The superior gluteal vessel, a branch of the internal iliac hypogastric artery, leaves the pelvis via the sciatic notch, staying against the bone and proximal to the piriformis muscle. If a graft is taken too close to the sciatic notch, the vessel may be cut and may retract into the pelvis. Nutrient vessels from the artery supply the iliac crest bone along the mid-portion of the anterior gluteal line, and the vessel may become an osseous bleeder as it enters bone via the nutrient foramen. To control bone bleeding, use bone wax on the raw cancellous surface of the pelvis after the graft has been removed. Bone. Avoid the sciatic notch. Breaking through the thick portion of the bone that forms the notch disrupts the stability of the pelvis. Removal of bone from the false pelvis proximal to the notch does not cause loss of stability. See Figure 7-6b. 665. How to enlarge the approach. Local measures. Place a sharp tip, right-angled talar retractor into the bone to retract the gluteal muscles away from the bone and increase the exposure. To increase the exposure further, lengthen the iliac crest incision and strip more of the gluteal muscles from the outer cortex to avoid working through a keyhole. Extensile measures. This incision cannot be extended. It is designed specifically for removing bone for graft material from the posterior outer cortex of the ilium. Inner cortex also may be taken, but soft tissue should not be stripped off the anterior approach to the pubic symphysis. The anterior approach to the pubic symphysis is an approach that is used almost exclusively for the open reduction and internal fixation of a ruptured symphysis or internal fixation of displaced fractures of the superior pubic ramus. Other uses include biopsy of tumors and treatment of chronic osteomyelitis. Because widely displaced symphysis injuries often are associated with urologic damage, obtaining a urologic assessment is advisable before undertaking open surgery, which often includes a retrograde urethrogram. Urethral catheter must be inserted before surgery. A full bladder will seriously interfere with the surgical approach. Position of the patient. Place the patient supine on the landmarks and then landmarks. The superior pubic ramus and pubic tubercles are easily palpable in all the pubic 600 incision. Make a 15 cm curved incision in the line of the skin crease. Set internervous plane. An internervous plane is not available for use in this approach because the rectus abdominis muscles receive a segmental nerve supply. They are not denervated even though they are divided by this approach. Figure 7-7 palpate the pubic tubercles. Make a curved incision in the line of the skin crease, centering at 1 cm above the pubic symphysis. Superficial surgical dissection. Incise the subcutaneous fat in the line of the skin incision, deepening the incision down to the anterior portion of the rectus sheath. Figure 7-8. Identify, ligate, and divide the superficial epigastric arteries and veins that run up from below across the operative field. Then, divide the rectus sheath transversely, about 1 cm above the symphysis pubis. The two rectus abdominal muscles now are visible. Figure 7-9. In most cases of rupture of 667, the symphysis pubis, one of these muscles will have been detached from its insertion into the pubic symphysis. Divide the remaining muscle a few millimeters above its insertion into the bone. Deep surgical dissection. Retract the cut edges of the rectus abdominal muscle superiorly to reveal the symphysis and pubic crest. Figure 7-10. If access to the back of the symphysis is required, use the fingers or a swab to push the bladder gently off the back of the bone. Palpation of the posterior surface of the body of the pubis is useful to identify the correct direction for the insertion of screws. This dissection is very easy to perform unless adhesions have formed due to damage to the bladder. Such adhesions make it difficult to open up this potential space. The peritonal space of Ritz's. Figure 711. The pubic symphysis and superior pubic rami now are exposed adequately for internal fixation. Bladder. The bladder may have been damaged during the trauma. If so, adhesions will have developed between the damaged bladder and the back of the pubis. Mobilization of the space of Ritz's, therefore, may lead to inadvertent bladder rupture. If fixation is considered in the presence of urologic damage, it is best to operate in conjunction with an experienced urologic surgeon. 668. Figure 7-8. Incise the fat in the line of the skin incision and retract the skin edges to reveal the anterior portion of the rectus sheath. Figure 7-9. Divide the rectus sheath transversely 1 cm above the symphysis pubis to reveal the rectus abdominis muscles and pyramidalis. How to enlarge the approach. Local measures. Because of the considerable amount of subcutaneous fat in this area, it may be necessary to extend the skin incision and superficial dissection in both directions to allow better visualization of the deep structures in obese patients. Extensile measures. The approach can be extended laterally to expose the entire anterior column of the acetabulum and the inner wall of the ilium. See ilioinguinal approach to acetabulum, page 378. 669. Figure 7-10. Divide the rectus muscles 1 cm above their insertion and retract their cut edges superiorly to reveal the superior ramus of the pubis. Figure 7-11a. Open the plane behind the symphysis pubis, using your finger as a blunt dissector. B. The pubic symphysis and superior pubic rami now are exposed. Anterior approach to the sacroiliac joint. The anterior approach to the sacroiliac joint offers safe, reliable access to that structure and allows anterior plates to be positioned accurately across the joint. It also permits the exposure of the inner wall of the ilium, allowing fixation of associated iliac fractures. Paradoxically, although the sacroiliac joint is one of the most posterior structures in the entire pelvic ring, the anterior approach allows greater exposure in 670. Controlled and does the seemingly more logical posterior approach because of the shape of the joint. Anteriorly, the joint is flat and directly available, whereas posteriorly it is overhung by the posterior iliac crest. Position of the patient. Place the patient in a supine position on the operating table and put a large sandbag under the buttock. This will push the iliac crest up toward the surgeon. Support the opposite iliac wing with a support attached to the operating table and then tilt the table 20 degrees away, allowing the mobile contents of the pelvis to fall away. Landmarks and incision. Landmarks. The anterior superior iliac spine and the anterior third of the iliac crest are subcutaneous and easy to palpate. Incision. Make a long, curved incision over the iliac crest, beginning 7 cm posterior to the anterior superior iliac spine at about the level of the iliac tubercle. Curve the incision forward until the anterior superior iliac spine is reached. Continue the incision anteriorly immediately along the line of the inguinal ligament for an additional 4 to 5 cm. Figure 7-12. Internervous plane. No true internervous plane is available for use. The approach consists simply of stripping muscles off the inner side of the pelvis. Because the bone is being approached via a subcutaneous surface, no muscle is denervated. Superficial surgical dissection. Deepen the skin incision through the subcutaneous fat onto the subcutaneous surface of the iliac crest. Two techniques can be used to detach the iliacus from the deep surface of the iliac wing. Bone block technique. Expose the deep fascia overlying the gluteal and tensor fasciae muscles at the point where it attaches to the outer lip of the iliac crest. Besides the periosteum of the entire anterior third of 671 iliac crest, and gently strip the muscles off the outer wall of the pelvis to expose about 1 centimeter of the outer surface below the crest of the ilium. Drill the iliac crest for easy reattachment. Using an oscillating saw, transect the wing of the ilium at this level, cutting only the outer cortex and the cancellous bone underneath figure 7-13. Next, crack the inner cortex with an osteotomy. This allows the anterior superior iliac spine to be detached along with the transected portion of the iliac wing figure 714. Figure 7-12, make a curved incision over the iliac crest, beginning 7 centimeters posterior to the anterior superior iliac spine. Soft tissue release only. Start just posterior to the anterior superior iliac spine and detach the iliacus muscle and its overlying fascia from the 672 deep surface of the iliac wing. Begin by using sharp dissection and then develop the plane using a swab used as a tissue expander. Deep surgical dissection. The iliacus muscle arises from the inner wall of the ilium. Detach it by blunt dissection. If the bone block technique is used as the dissection is deepened, the detached anterior superior iliac spine, which still is attached to the lateral end of the inguinal ligament, must be mobilized. This block of bone and muscle must be moved medially. To accomplish this, divide some fibers of both the tensor fasciae and sartorius muscles figure 715. Note that the lateral cutaneous nerve of the thigh is about 1 centimeter distal and medial to the anterior superior iliac spine, and may have to be divided to permit this mobilization. Remaining strictly in a superiosteal plane, strip the iliacus muscle off the inner wall of the pelvis to expose the underlying sacroiliac joint, see figure 7-15. The distance is surprisingly short. As the muscle is stripped off, some nutrient vessels will have to be detached from the inner wall of the pelvis. Bleeding usually can be controlled by bone wax. L4, L5 nerve roots and the lumbosacral trunk run along the anterior surface of the sacrum approximately 1.5 centimeters medial to the sacroiliac joint. Therefore, do not continue the dissection more than 1.5 centimeters medial to the sacroiliac joint. If a standard 3.5 mm plate is used to stabilize the joint, place the plate so that only one screw hole is placed medial to the joint. Using two holes of the same plate will endanger the nerve root, see figure 7-15. Insert. Mobilizing the iliacus muscle off the inside of the pelvis with a large bone block allows the muscles to be reattached securely with screws during closure. The muscle then resumes its anatomic position, and the dead space beneath it is obliterated. If the bone block technique is used, failure to securely reattach the iliac crest will produce impaired function, a poor cosmetic result, possible chronic pain, and a high risk of hematoma formation. 673. Figure 7-13, strip the muscles from the outer wall of the pelvis. Prodrill the iliac crest. Divide the outer cortex 1 centimeter below the crest using an oscillating saw. Nerves. The lateral cutaneous nerve of the thigh may have to be divided during the mobilization of the anterior superior iliac spine. This will cause some 674. Numbness of the lateral aspect of the thigh. Even if the nerve is not transected, a neuropraxia due to retraction is common in patients. Should be warned that an area of numbness on the lateral aspect of the thigh may occur following surgery that in some cases may be permanent. L4, L5 nerve roots and the lumbosacral trunk crosses the anterior surface of the sacrum approximately 1.5 centimeters medial to the sacroiliac joint. If plates are applied too far medially on the sacrum, the nerve will be damaged. This nerve root marks the medial limit of the approach. Sacral nerve roots. The sacral nerve roots can be damaged at the point where they arise from the sacral foramen. For this reason, the dissection cannot be carried further medially than the sacral foramen. The sacral nerve roots are not usually exposed during this approach. They can be at risk at 2 stages of the operation. If sharp-pointed retractors such as Holman are used medially, great care should be taken that the point of these retractors is not inadvertently inserted into a sacral foramen. Sacral nerve roots can also be entrapped under the medial end of plates applied to the anterior surface of the sacroiliac joint. Meticulous preoperative planning will allow you to know exactly how many screw holes can be inserted safely into the sacrum without endangering the sacral nerve roots. In most cases, only one screw can be inserted. 675. Figure 7-14, crack the inner cortex using an osteotomy to complete the iliac osteotomy. Vessels. Relatively large nutrient vessels often are avos from the inner wall of the ilium. Bleeding from these vessels can be controlled by pressure or bone wax. How to enlarge the approach. 676. Local measures. Paradoxically, the key to adequate exposure of the posteriorly placed sacroiliac joint is adequate anterior dissection. The lateral end of the inguinal ligament and its attached anterior superior iliac spine must be mobilized to visualize the sacroiliac joint adequately. Extensile measures. The approach may be enlarged into an extended ilioinguinal approach that provides access to the entire anterior column of the acetabulum. This approach is discussed later in this chapter, page 378. Figure 7-15, strip the iliacus from the inner wall of the pelvis to expose the underlying sacroiliac joint.